Hi, Assalamu alaikum. Good morning, everyone. There is a morning, morning, and there is a evening. There is a good evening for everybody. It's me, Dr. Muhammad Kazafi, and you are watching Dr. Muhammad Kazafi Views. I wanted to present one very, I think, not common, but definitely it's an important value topic of the neurosurgery, and this is called the hypothalamic hamartomas. And regarding this, before I want to go in detail, I want to show you I wanted to show this picture in front of you people. This is the MRI, which is showing one slide of the sagittal, one slide of the axial, and the one slide of the coronal plane. And here you can appreciate there is a T2 weighted images of the at the floor of the third ventricle, and this is the area we have to notice where we have to identify the hypothalamic hamartoma. And this anatomy you should consider in your mind, and definitely I will talk about it. Definitely you can understand, and you can apply, and you can increase your knowledge by this way. Thank you so much. For the further explanation and understanding, and for the further, we can say, uh, understanding, you can appreciate here. There I am pointing here. This is the area where is the you can appreciate the hematoma, and that's why I was telling you have to understand the third ventricle, or the third ventricle anatomy, or these things, so you can appreciate where can be tumor and how can be tumor resected or removed. So I want to tell you one more thing here. So before going to the proper lecture, I wanted to show one more picture here, and I am pointing here. This area you can appreciate, and this is suggestive for the, definitely it is a hypothalamic hamartoma. And now I want to explain you in a small lecture, and then try to give you one case for the analogy, so you can understand it and you can correlate with your knowledge or experience. So we are proceeding. So as you know, we are talking about we are just discussing right now about the hypothalamic hamartoma. And the hypothalamic hamartomas are congenital non-progressive lesion in the hypothalamus, and these lesions usually develop a disabling course and presenting with the multiple seizures, seizure type, cognitive decline, and we can say the psychiatric symptoms. And this activity reviews the evaluation, treatment, and the management of the hypothalamic hamartomas, and explains the role of the interprofessional team in managing patients with this condition. So identify the etiology of the hypothalamic hamartomas is the prime choice. And the hypothalamic hamartomas are the congenital non-progressive lesion in the hypothalamus, and that occur during the fetal development, and two anatomical subtypes are recognized depending on the location of the mass-like lesion. So the first type in the intrahypothalamic lesion that connect with the posterior hypothalamus and the third ventricle, and they appear near the mammillary body and are usually associated with the, we can say, the gelastic seizure. And the second type in the parahypothalamic or pedunculated lesion located near the anterior hypothalamus and the cinereum, or we can say there is the pituitary stalk, and attached only to the floor of the third ventricle, and it is usually associated with the sign of the precocious puberty caused by the increasing the release of the gonadotropin releasing hormone. And these lesions typically develop a disabling course, and presenting with the multiple seizure type or cognitive decline and the psychiatric symptoms. So the hypothalamic hamartomas occur as sporadic abnormality unlinked with the congenital malformation or the family history, and nearly 95% of the cases are sporadic, although 5% of the cases are associated with Pallister Hall syndrome, which present with the dysmorphology in the hand, feet, and we can say the larynx or the anus and the hypothalamus. So the larynx, it behave like the bifid epiglottis, or the feet you can see the postaxial polydactyly and the syndactyly, and some congenital anomaly in the anal area, and definitely the hypothalamic hamartomas we are already discussing here. So now the syndrome is associated with the mutation in the GL13 gene expressing a transcription factor in the sonic hedgehog intracellular pathway, and the patient with the sporadic hamartomas we can present, or sorry, it can present in up to 25% of the cases the somatic mutation of the GL13, and the somatic mutation are found in, we can say, the 40% of the patient. Hypothalamic hamartomas is a rare condition, only 1 in 100,000, and with the slight predominance in the male, and it has no geographic preference and not related to the specific ethnic group, and no identified maternal risk factor or the fetal exposure have been identified till now. So hypothalamic hamartomas causes gelastic seizure due to the, we can say, the intrinsic epileptogenesis and the molecular etiology responsible for the epileptogenesis is not well understood, and although some studies include the small neuron in these lesions have the intrinsic membrane capability of causing depolarization. Hypothalamic hamartomas consist of the cluster of a small neuron intermixed with the glia and large neurons, and the neuronal cluster have been traditionally described histopathologically as a configuration of grapes, and the clusters can be the functional unit of the epileptogenesis of these lesions, and they have very low Ki67 level, indicating a low proliferative capacity. So there are two clinical presentations encountered in the hypothalamic hamartomas. One is the epilepsy and the related neurobehavioral symptom, and other is a central precocious behavior and puberty. So we will talk little bit about that, then we will go for further. Yes, I want to talk about the two clinical presentation, and it is very important to understand which is the epileptic or epilepsy and related neurobehavioral symptom, and other one is a central precocious puberty, and the patient with the epilepsy present with the gelastic seizures at their most common symptom, usually starting during infancy, and associated finding are the developmental delay and the cognitive decline, and the we can say the psychiatric symptom associated with lesion attached to the posterior hypothalamus near the mammillary bodies. Almost 40% of the patient that present with the gelastic seizures or demonstrate precocious puberty. So when both symptoms appear simultaneously, they tend to be associated with more extensive lesion on the magnetic resonance imaging and involving both the anterior and posterior hypothalamus. So what I am trying to tell you, when both symptoms appear simultaneously, they tend to be associated with more extensive lesion on the magnetic resonance imaging, and MRI involve both the anterior and posterior hypothalamus. And the gelastic seizure is the most common symptom in patients with the hypothalamic hamartomas, and it is usually the first seizure type, and the diagnosis is generally made by unusual presence of the, we can say, the laughing spell and characteristic start at any year of the age and eventually disappearing by 10 years of the age, and the average duration of this spell is approximately 1 to 30 seconds and may occur multiple times per hour in the most severe cases, and they may or may not be associated with altered loss of consciousness, and in some cases other seizure type can be present. In nearly 75% of cases, seizure subtype can be very disabling, or we can say such as the tonic-clonic seizures, complex partial seizure, drop attacks, and the atypical absence. And some patients have the episodic that mimic crying and are called, and we can say the gelastic seizures, and are rarely a patient can present gelastic seizure and then do not have the hypothalamic hamartoma. They have been attributed to a lesion in the frontal and the temporal lobe. Cognitive deficits are prevalent in patients with the hypothalamic hamartomas and the epilepsy, and difficulty in the short-term memory and processing speed and diminished intellectual disability have been found in neuropsychological testing in nearby 50% of the cases, and factors that predispose to more significant cognitive impairment include the higher number of anti-epileptic medication use and the larger hamartoma size, or we can say the younger age of seizure onset and the higher seizure of frequency. Behavioral and psychiatric symptoms are relatively common, such as the we can say the oppositional defect disorder or attention deficit, hyperactivity disorder, conduct disorder, mood disorder. So most patients experience worsening symptoms throughout their lives, and patient also can present with the isolated precocious puberty and with lesion attached mainly to the anterior portion of the hypothalamus near the cinereum. So with appear pedunculated below the third ventricle, the symptoms of the precocious puberty are relevant of they initiate before age of the 8 years in girls and 9 years in the boy, and the symptom can present as early as 1 year of the age, and these may consist of the short stature, breast development, and the pubic hair presence, and the mutation of the sexual reproductive organs, and these and we can say the deepening of the voice and the acne, all are coming because of this precocious puberty. So these the two presentation I just explained you in little detail, because if you could understand in detail, then you can apply and with your knowledge for further. So that's why I told you the third ventricle and around its anatomy, and I try to explain you on the MRI, and definitely it is good and to understand and for a further explanation. The evaluation regarding the MRI brain with the without contrast is the gold standard for the diagnosis, and it is essential to notify radiologists to focus imaging in the hypothalamic region to avoid, we can say, the misdiagnosis. And the hypothalamic hamartomas differ from the normal gray matter due to decreased intensity in T1 weighted images and increased intensity in the T2 weighted images, and higher T2 signals is associated with the higher glial content with the peripheral subependymal, we can say the band consists of the when a multilinated fiber, and these lesions do not enhance with contrast. So the hypothalamic hamartomas can also be associated with the presence of cysts, and we can say they specifically arachnoid cysts, and currently it is not clear if the cysts are intrinsic or extrinsic due to the lesion. So the hypothalamic hamartomas do not enlarge and they expand with the brain growth. Thus the relative size compared with the brain will always be the same. And the head computerized tomographic scanning shows a small non-enhancing lesion near the interpeduncular or suprasellar cistern, and usually isodense to the, we can say, the brain, and this imaging tool is, we can say, now considered inadequate for detecting the hypothalamic hamartomas and add additional unnecessary radiation exposure to the patient. So the MRI is a better choice as compared to the to the CT scan. Electroencephalography usually appear normal during the gelastic seizures or gelastic seizures, how you pronounce it's up to you, although it may be beneficial when other seizure types are present, and continuous video 24-hour EEG should be able to film the patient in a laughter spell, but do not show any electrical or ictal activities during the gelastic seizures. So, as I mentioned, interictal or ictal EEG may show focal or multifocal or general, we can say, the spikes in patient with the other seizures type and may be beneficial for the diagnosis. So the depth electrode, or we can say recording, have been demonstrated that gelastic seizure originate from the hypothalamic hamartomas. Simple photon emission computerized tomography shows hyperperfusion by the hamartoma after gelastic seizures and the normal perfusion in an intracranial phase, and the magnetic resonance spectroscopy shows a decrease in NAA is to CR ratio or creatinine ratio. So in patient with the hamartoma compared with the hypothalamus of the healthy patient, hypothalamic hamartoma have increased gliosis and decreased neuronal concentration as compared to the normal hypothalamus. This is the histological explanation for this thing to understanding. Each patient unique circumstances such as the clinical course, symptoms, and the exact anatomy of the lesion need to be analyzed to select the most appropriate treatment. And for minor clinical manifestations such as the inconsequential gelastic seizures, observation is recommended, as brief and frequent episodes are usually not disabling. Sometimes surgery is performed to prevent secondary epileptogenesis, where uncontrolled seizure can provoke epileptogenesis to an indistinct cortical regions. Anti-epileptic medication usually do not control or improve the gelastic seizures. They are actually mostly used for the control of the associated tonic-clonic seizures and the complex partial seizures and the drop attacks and the atypical absence, and they are less successful in diminishing the seizures associated with the hypothalamic hamartomas, and the surgery is often recommended. So gonadotropin releasing hormone agonist sometimes used, and this precocious puberty can usually be treated successfully with this medication, and leuprolide acetate inhibit the release of the gonadotropin releasing hormone that is required to trigger the puberty, and it is generally administered intramuscularly and once monthly for the duration that puberty need to be supported. So surgically, the gold standard treatment of open surgical resection of hamartoma, it provides the best outcome in seizure, cessation, and halt neurocognitive behavior and psychiatric symptom, and the neurosurgeon can select the ideal surgical approach for each case depending on the size of the hamartoma, its anatomically relationship to the hypothalamus, surrounding neurovascular structure, age, and experience with the particular procedure. The most common type of treatment has been resection by a craniotomy, and several approaches can be used and include, we can say, the transcallosal intrafornicial resection, or we can say the pterional resection. So the transcallosal interfornicial resection, or the pterional resection, or the transtemporal transchoroidal resection, or the combined resection for extensive lesion. These can be done even though with the help of the image guided endoscopic procedures. I want to repeat, image guided endoscopic procedure definitely is a little tough learning curve, but definitely they are providing more promising result and the lesser morbidity and the lesser post-operative complications because the endoscope is not no need to cut too much and no need to retract too much and nowadays it is getting popular and the people those have the expertise in that and they are very good in with the anatomy with these structure. Definitely we have to be good in the anatomy, but and it is also important to provide the direct access to the hypothalamic region. Nevertheless, it is limitation due to the narrow corridor for the working area surrounding by the internal carotid, optic nerve, optic chiasma, phonesis, internal cerebral vein, infundibulum, and limited access to the third ventricle. So the transcallosal interphoneal approach provides the ideal access for the intraventricular hamartoma and is the favored, we can say, the approach by many neurosurgeons, and the transventricular endoscopic resection should be used nowadays. Identifying, separating the borders of the hamartoma from the hypothalamus and the mammillary body is very very difficult, although its removal provide a greater than 90% reduction in the seizure frequency, especially in the gelastic, or we can say the gelastic, or we can say the neurocognitive, behavioral, and psychiatric symptoms. Gamma knife radiosurgery is getting popularity all over the world, and the gamma knife radiation is a non-invasive radiosurgical technique for causes that causes damage to the lesion, and the exact mechanism of the seizure control has not been determined due to the lack of the lesion necrosis on follow-up MRI, and this finding suggests that the modularity event with the diminished vascular supply and the gliosis can be responsible, and it serves as an excellent tool to treat lesions that are difficult to resect without causing neuroendocrine deficits. But therapeutic effect typically requires 6 to 18 months, but sometimes up to 3 years. Gamma knife radiosurgery provides seizure freedom in 40% of the patient treated and provide a good alternative for the treating small and the medium-sized lesions. Stereotactic thermoablation, the lesion is heated. Actually, the thermoablation, as I mentioned here, the lesion is heated to approximately 60 degrees centigrade to damage the tissue and prevent its ability to generate seizure. So treatment immediately provides results, and the large lesion need several passes to treat the entire lesion. Radio frequency thermoablation seizures control in up to, I must say, 71% of the patient, and 1/3 require multiple treatment, and it provides an excellent alternative to treat cases that do not respond to the open surgical treatment. And 1/3, that's why I mentioned the 1/3 people, they need the multiple treatment. And this radio frequency thermoablation seizure control is up to 71%, good enough, I think. And the laser mediated ablation heat the lesion using the real-time MR thermography. It can obtain the seizure control in nearly 60% of the cases. So these are the modalities, and they are offering some promising results somehow, and definitely the learning curve and the time will tell how much it can be beneficial. So the tumor that occur in the same region of the hypothalamic hamartoma would be principal differential diagnosis such as the craniopharyngioma, astrocytoma, optic glioma, meningioma, and these lesions do not cause the gelastic or gelastic seizures. However, they can be associated with the neuroendocrine axis disruption, which can produce a precocious puberty here also. The prognosis surgery can potentially achieve a 90% reduction in the seizure frequency, and we can say here, and the gamma knife radiotherapy provides seizure freedom only 40%, and the radio frequency thermoablation results about 71% of the patient get the good control, and the laser mediated can get the 68%. So we can say the laser mediated also doing the same percentage as the radio frequency is doing. Or we can say the leuprolide acetate inhibitor, which is good for the precocious puberty until adequate age, and when it is then suspended, then the age will come, then you can suspend it. So the anti-epileptic medication usually do not control or improve gelastic seizures, and are less successful in the controlling other seizure types. So no medication for controlling the seizure, gelastic seizure here. And the higher number of the anti-epileptic medication uses, and the large hamartoma size, and the younger age seizure onset, and the or we can say the higher seizure frequently predisposed to the great cognitive impairment. Complication, the hypothalamic hamartoma may lead to the systemic complications such as multiple disabling seizures, such as the tonic-clonic seizure, complex partial seizure, drop attacks, cognitive decline, psychiatric symptoms, or the attention deficit, hyperactivity disorder, or we can say the developmental delay, short-term memory, or the reduced processing speed, or we can say diminished intellectual disability, short stature, acne. So the treatment modality can lead to complication, and surgical diabetes insipidus. Surgery can cause diabetes insipidus, meningitis, ischemic stroke, infarction, hemorrhage, and short-term memory deficits. And the stereotactic radiosurgery provide a slow treatment response. Therefore, the patient remain exposed to the risk of the persistent seizure for up to the 3 years. And the thermoablation, injury to the neurovascular structure, temperature control problem, and or we can say the hyperphagia or hyponatremia, and the Horner syndrome, amnesia can happen. And here we need the definitely neurosurgeon, pediatric especially neurosurgeon, neurologist, pediatric neurologist, neuroradiologist, pediatric endocrinologist, pediatrician, and the parent need to be educated about the etiology, clinical presentation, and the prognosis of the hypothalamic hamartomas, as several treatment modalities are available, and they have to inform about the risk and the benefit of each treatment modality, allowing them to make informed decision. And invasive treatment provide the most excellent option for the seizure prevention, and they are highly recommended. Hypothalamic hamartomas are the benign lesion, and parent must be informed to avoid the concern of any potential malignant transformation or metastasis. Puberty will typically occur when after the use of the gonadotropin releasing hormone agonist, and the children will develop normal after surgical or ablative procedure. And if any particular treatment modality fails, then patient will continue with disabling seizures and declining neurocognitive behavior and progressive neuropsychological difficulty. Therefore, a combination of treatment and modality should be attempted. As I mentioned before, the hypothalamic hamartoma frequently poses a diagnostic dilemma, and the patient may exhibit rare symptoms of the gelastic seizures or precocious puberty associated with the neuropsychological and psychiatric symptoms. The etiology is usually suspected, but it is difficult to identify without proper imaging studies. While the pediatrician is almost always involved in the care of the patient with hypothalamic hamartomas, and it is essential to obtain an evolution with an interprofessional team of the specialists that include the neurosurgeon, neurologist, and pediatric endocrinologist. So here, sometime as I finished, or as till now, what I talked about the hypothalamic hamartomas, uh, I and I didn't mention there is any aggression, and even though the CT scan showing the isodensity, even though the MRI showing the hypointensity, and the only difference on the histologically is there the more gliosis and the the less neuronal cell, but definitely sometime, and this we can say the hypothalamic and hamartomas shows the aggression, and how they are showing the aggression and what kind of the aggression they are showing, which I wanted to explain in front of you. Even though I am considering the longevity of the of the lecture, but these lectures are not for the entertainment. It is especially for the knowledge and sharing the knowledge, and that's why, and I wanted to present in that manner. I hope you will like it. So I'm proceeding and presenting few things about the aggression of the hypothalamic hamartoma. These MRI axial and sagittal sections and showing the hamartoma, but hamartoma, it is not showing the hamartoma of the hypothalamus, but also showing the here, and you can appreciate the aggressiveness of here, and then I will talk about the aggressiveness now. The hypothalamic hamartoma are the benign congenital tumor that arise from the ventral hypothalamus, and the research has identified the two clinical phenotypes of the hypothalamic hamartomas, namely parahypothalamic, and other one is intrahypothalamic. One is parahypothalamic, other one is intrahypothalamic hamartomas. Parahypothalamic hamartomas, also known as the pedunculated, are attached to the anterior hypothalamus, and the parahypothalamic hamartomas are highly associated with the central precocious puberty, and whereas intrahypothalamic hamartomas attached to the posterior hypothalamus correlate highly with the treatment resistant epilepsy. And this treatment resistant epilepsy mainly start with the gelastic or the laughing seizures, and which later developing into the other resistant seizures type, including the localization related and the generalized seizures. Nearly 40% of the patient with hypothalamic hamartoma have both central precocious puberty and epilepsy. However, this is more related to the longer lesions that arise from the anterior and posterior hypothalamus. The intrahypothalamic subtype of the hypothalamic hamartoma is particularly also associated with the neurobehavioral comorbidities, include the cognitive impairment and the psychiatric symptoms. And the cognitive impairment varies in patient from mild to severe depending on the earlier age of the onset of the first seizure, frequency, size, and the number of the epileptic drugs. And the psychiatric symptoms are a common comorbid feature of the hypothalamic hamartomas with epilepsy, and they are the most disabling in patient and are significant challenging for the patient and their families. So the most commonly the psychiatric symptoms present with the we can say the externalizing behavior such as the aggression and the rage, attack, or the patient can also have a reduced threshold for the frustration with extensive reactivity to minor stimuli, and which can also result in a destructive physical feature. And hamartoma is, the discrete lesion that resembles a neoplasm, but often arise from an, we can say, the errant organ or contain an atypical portion of the tissue element. But the hypothalamic hamartomas are the rare congenital benign tumor that contain atypical portion of the neuronal tissue element, and the hypothalamic hamartomas develops in the 5th to 6th week of the gestation, that appears in and or around the hypothalamus, arise from the infundibular recess and the mammillary body. And there is a theory that defect in the fetal development of the hypothalamus resulting in the development of the tumor, and the pathologically hypothalamic hamartomas consist of mature neuron and the glial cell with range in size from 10 to 30 millimeters. And the cause of the hypothalamic hamartoma remain unknown, but the cases are usually sporadic with no identified familial history, and the patient remain the only affected individual. However, hypothalamic hamartomas are also associated with the rare genetic disorders such as the Pallister-Hall syndrome. And this Pallister-Hall syndrome is an autosomal dominant disorder, we can say, caused by the mutation to the GL13 gene, which classically present with the hypothalamic hamartoma and polydactyly. So the estimated prevalence in only one per, we can say, 50,000 to 100,000 in children and adults, and the prevalence of the hypothalamic hamartoma with only precocious puberty remain unclear. For hypothalamic hamartoma with epilepsy, males are at slight higher risk than the female, with the ratio of 1.3 to 1, and the hypothalamic hamartomas occur worldwide with no specific geographic concentration of the cases. And the current thinking is that all ethnic groups are at equal risk and with no identified maternal risk factor or the fetal exposure. And as I mentioned before, the clinical presentation of hypothalamic hamartomas depending on their region of the attachment to the hypothalamus, and clinically hypothalamic hamartoma present in the two recognized subtypes. One is a parahypothalamic and other one is a intrahypothalamic. So the parahypothalamic hamartoma are known as the pedunculated and occur in anterior hypothalamic thalamus and arise from the inferior surface of the hypothalamus to the cinereum. And this subtype of the hypothalamic hamartoma is associated with the central precocious puberty, and the central precocious puberty associated with the hypothalamic hamartoma start early at an average age of 3 to 7 years in boys and 2.5 years later, 2.5 years in the girls. So conversely, intrahypothalamic hamartoma, also known as sessile, and occur in the posterior hypothalamus with and the attachment level at the mammillary body. And this intrahypothalamic hamartoma are associated with gelastic or the laughing seizure, epilepsy, cognitive impairment, and the psychiatric symptoms. So the gelastic seizures are rare from the seizures and are the rare form of seizure and characterized by the inappropriate smiling, giggling, laughter associated with the video electroencephalogram changes and unrelated to the external or the interpersonal stimulation. And these seizures classically occur in infancy with increasing frequency, and we can say the periodicity. And the mean age of the presentation of the gelastic seizure is 2.8 years, with the age of out ranging from 1 month to 15 years. Gelastic seizure can be precursor to the other seizure type, cognitive deterioration, and behavioral abnormalities. So the clinical spectrum of the hypothalamic hamartoma associated epilepsy ranging from being sporadic and the easily controlled partial seizure to seizure partially responsive to the epileptic drugs and catastrophic course that require the surgery surgical intervention. The cognitive impairment can present as the laugh delay with the learning disability, and the behavioral disorder are associated more commonly with the hypothalamic hamartomas and the gelastic seizure, and these include attention deficit, hyperactivity disorder, aggressiveness, anxiety, oppositional defense disorder, and conduct disorder. And other behavioral disorder include age, temper, tantrum, and violence, anxiety, mood disorder, and can present as the phobia, the most or post-traumatic stress disorder, avoid disorder, major depression, and dysarthria. So these all are the behavioral and the cognitive disorders. Here we have to discover the patient with the gelastic seizure present with the effective aggressiveness, and the definition of the effective aggression is the being out of control and the damaging one's property, physical harm to oneself, aggressive without a propose, or aggressive with the stronger children when aggressive. So with the express humor after aggression, some children also present with the predatory aggression, and the predatory aggression include the ability to control their behavior when aggressive, or we can say the protect oneself when aggressive, fight with the weaker children and tries to get some time, but often being aggressive. So more commonly, patients with the hypothalamic hamartoma and the gelastic seizure support effective aggression, and these aggressive episodes arise quite suddenly and are not motivated by ill will toward the victim. So the other predictive factor associated with the increased likelihood of aggression, or we can say, includes male gender and the presence of the intellectual disability, or we can say the younger age at the time of the first seizure, multiple seizure postulates are there. The seizure activity in patient with the hypothalamic hamartoma is in contribution factor to the neurobehavioral deficit, and the cause of the rage and the expression are poorly understood but thought are influenced by the gender and hormonal dynamics. That's why this aggression, that's why I wanted to present this thing, because before I wanted to give you some introduction for that, and now I wanted to present this thing. I know there is a longevity in the topic sometime, and the people wants everything in a glimpse, or we can say in a few minutes, but it is not entertaining lecture. These are the lecture to understanding the knowledge about these kind of diseases, and definitely I want to try to satisfy my audience, whatever the audience are we have, and they can understand and they can express easily. So as you know, since hypothalamic hamartoma present with the plethora of the psychiatric symptom, and the patient need a thorough neuropsychiatric evaluation process, and the diagnostic tool include the diagnostic and the statistical manual of the mental disorder, and the overt aggression scale can be useful. So the other aggression scales, such as the Vitilio aggression scale, differentiate effective and predatory aggression, and definitely magnetic resonance imaging confirm the presence of the hypothalamic hamartoma, and the MRI is a primary diagnostic tool to diagnose the hypothalamic hamartoma, as surgical specimens are difficult to obtain. But the central precocious puberty may be caused by the excessive secretion of the gonadotropin releasing hormone from that lesion. So the child and adolescent psychiatric frequently have to evaluate in a youth presenting with the rage and anger, or distinguishing between the predatory or effective aggression at this time is very important. Also, if the patient present with the history of the inappropriate smiling or giggling, this should alter the psychiatrist that gelastic epilepsy or gelastic epilepsy should be present, and the patient should obtain referral for through neurological assessment. Gelastic seizure often fail to demonstrate EEG, therefore the video EEG is a recommended approach, and the video EEG capture the gelastic seizure with head deviation and twitching, And further, if the patient present with the finding of the aggression and precocious puberty, a complete thorough assessment by an endocrinologist is also required. Regarding the treatment, I already mentioned that the gelastic seizures associated with the hypothalamic hamartoma are complicated to treat or manage, and these seizures are refractory to the medical treatment, and report exists for surgical attempt to control the seizure. However, some instance for surrounding hypothalamic tissue interface with the safe surgical access. No alternative modality include stereotactic targeted radiation therapy or the radiofrequency lesioning or the thermoablation lesioning, targeted thermoablation lesioning, or the recent studies have reported that the complete resection is not necessary, and disconnection the tumor is sufficient for the seizure control. Therefore, the less invasive modalities are increasingly being used, and the main disadvantage of the non-surgical approach are delayed effect on the seizure control, which usually take out the 6 months, and the radiation damage to the surrounding vital structures such as the optic tract, optic chiasma, or the lower or the optic nerve, and the lower efficiency of the seizures control in contrast to the open surgical approach. And if precocious puberty is the isolated finding with the hamartoma, then the medical management is focused on the suppressing the pubertal development. An example of this treatment planning would be the administration of the gonadotropin releasing hormone along and a long-acting luteinizing hormone releasing hormone analog suppress the gonadotropin secretion, and therefore treatment with the luteinizing hormone releasing hormone analog is the first choice. However, does not help, then the surgical removal is recommended. So in contrast, the intra-hypothalamic hamartomas, para-hypothalamic hamartomas are relatively easy accessible for the surgical removal. So therefore, the true proposed treatment algorithm for the behavioral and psychiatric symptoms in patients with the hypothalamic hamartoma, there is also yet no documented, but the specific pharmacotherapy for the psychiatric symptoms in patients with the hypothalamic hamartoma. Behavioral difficulties are addressable through parent management training, and the training, we can say, involves the teaching parent strategy to increase the pro-social skill and decrease disruptive behavior in children. An example of the parent management training is a brief behavioral intervention program, and the program demonstrates successful results in treatment of the symptoms of the ADHD and disruptive behavior in children with the parahypothalamic hamartomas. And the behavioral symptoms are common in children with epilepsy. Often parents report their children being more restless or the irritable because of seizure. Controlling seizure, ultimate control, aggressive seizure, aggressive behavior definitely should be controlled. And the surgical removal of the hypothalamic hamartoma is a more definitive treatment in controlling the seizures. So, the prognosis depends upon the numerous factors such as the size, location, early manifestation of gelastic seizure, behavior, cognitive impairment, and the central precocious puberty and the large sessile hypothalamic hamartomas are likely to present with all of the above features. And the success rate for the gonadotropin releasing hormone agonist therapy is high in treating central precocious puberty, and the monitoring pubertal progression is required. However, regular testing for the luteinizing hormone and the sex steroid can further confirm the treatment efficacy. And when the puberty is desirable, then the clinician can discontinue the hormone therapy, and the long-term outcome of the children involved and the boy treated with the gonadotropin releasing hormone therapy appears favorable. And the gelastic seizures are quite distressing, and the patient and the family, and they need the anti-epileptic drugs, but anti-epileptic drugs are not working there. Then the need of surgery and the endoscopic disconnection of the hypothalamic hamartoma is achieved by the help of endoscopy only in 50%. But the complication with the open surgery is very, very high, so it's better to go by the gamma knife or thermoablation or endoscope or stereotactic radiosurgery. These are, I think, the better option. I want to uh, a 10-year-old girl is referred to the precocious puberty workup, and her further notice that she has become inappropriate in her laughter, and she had a difficulty passing her classes, and she performed was a top student and quite child, but the mother is not sure if she has ever had a seizure, but she has a appointment with the pediatric neurologist in 3 months, and the differential diagnosis such as the optic glioma, hypothalamic gliomas, or we can say the suprasellar germ cell tumor or the craniopharyngioma. So here I want to go for the initial imaging, and as we went for the initial imaging, and we found there is on the MRI, and MRI is a choice of investigation, and in these lesions, and which is showing there is we can say the low grade, it could be a low grade glioma because it behave like if you see here the pre-contrast MRI revealed a large iso-intense suprasellar mass in the close proximity to the optic chiasma and the nerve, and the posterior pituitary bright spot is observed, and the axial T2 weighted sequence revealed the hypothalamic location and the imaging description and the differential. So the neuroradiographic differential includes a low-grade glioma, hypothalamic hamartoma, and the germ cell tumor. So the pure germinomas versus non-germinomatous germ cell tumor are included in that. So the further workup such as the EEG to confirm the presence of the gelastic seizures, which would be the typical for the hypothalamic hamartoma, and the hypothalamic hamartoma are the rare benign tumor type that only affect approximately 1 in 200,000 people, and the symptom can include the seizure, precocious puberty, hormone imbalance, cognitive impairment, behavior and the emotional and a problem, gelastic or the laughing seizure, and usually being in infancy and may be difficult to distinguish from the normal laughter, or either onset seizure may involve in the complex partial, generalized and the drop seizure, and the tantrum rage attacks, or we can say the social isolation may use. And so the treatment option, we have the surgical, which is called the transcallosal So as I was mentioning here, definitely we have the different surgical options, and the best surgical option for the transcallosal approach for the orbitozygomatic craniotomies and the endoscopic surgery. Nowadays the people are getting the mastery in that, and they are trying to do some magic by the help of the endoscopic way, and this is the least morbid and the least traumatic for the brain and the nervous tissue, and simultaneously it is giving the you don't have to bother for the retraction of the brain tissue, and when you are avoiding the retraction of the brain tissue, everybody knows that there is the least chances for the morbidity here. And the gamma knife stereotactic radiosurgery or the conventional stereotactic radiosurgery also included, but the gamma knife only providing the 50% of the 50% of the control over the gelastic seizure, but the thermoablation giving the thermoablation and giving the 70% gelastic seizure control. And if we are giving it by the way of the laser, and the laser also providing a laser with the help of the MRI, and it provide about a 67% control over the gelastic seizure, because the removal of the hypothalamic hamartoma is not the choice, or is not the option, or not the goal, but the disconnection is good enough to do that. And now I want to explain
a little bit about the surgical technique. The patient is placed in a supine position in a Mayfield 3-pin fixation, and for here I want to show you a picture which is very much expressive, and it will say by themselves 1,000 words. For yes, this is the position I wanted to show, when we are placing the patient in a Mayfield, and I muffled the face because of the people cannot recognize the face, and this will explain. I think this single picture says 1,000 words by themselves. So as I was telling about that, the surgical technique, the patient is placed in a supine position in Mayfield 3-pin fixation with the head in either the neutral position or slight rotated to the contralateral side about 20 to 30 degrees, and preferably a right-sided approach is chosen. So the stereotactic registration should be performed, and good accuracy is ensured. So the skin incision is usually the semi-arcuate, or we can say the running from within the hairline, but 2 to 3 centimeter lateral to the midline to the point slightly above the anterior border of the ear. Therefore, runs parallel to the portion of the coronal suture and ends at the sphenofrontal suture. So the scalp incision using Colorado tip monopolar cautery could be created, and the craniotomy should be performed using a craniotome, and the flap is centered on the coronal suture and can be oriented slightly more anterior and posterior depending upon the location of the pathology, and the dura is opened in a horseshoe fashion with its base on the we can say the sagittal sinus, and the cortical veins draining into the sinus should be protected, and the ergonoid incision allows the visualization of both the cingulate gyrus, and the paired corozomarginal artery must be identified, or we can say the coursing superficial to the cingulate gyrus, and must be protected, avoid to injure. This is the thing, that's why the endoscope has a superiority over that, because the endoscope needs the lesser area to traverse this scope to that area, and if we can go the microscopic procedure, then we have to do the bigger incision, bigger surgery, and more morbid as compared to the endoscope. But I must want to tell you, when you are going to with the help of the endoscope, you should be familiar with the image guided system. If you have a stealth station Meditronic system, if you have guided, I'm not actually proposing the Meditronic, but I'm just giving the example for the analogy, so that the Meditronic system, which I have been trained during my residency, and that I have used that multiple times, and it is good one, and now it is more advanced, their softwares are more advanced. Now I'm coming to that where we left that the cingulate gyrus, which are often adhere to and separate, and the very we can say the very wide corpus callosum overlying the paired pericallosal artery is visualized, and the midline interhemispheric approach is performed with the small corpus callosotomy just behind the genu, and the midline transseptal dissection on the interfornicial approach between the uppermost section of the column before they converge to form the arches of the fornix is next. Entering the anterior end of the roof of the third ventricle, remove the hamartoma using the long curved, and we can say the micro tip of the ultrasonic aspirator, and the consistency of the hypothalamic hamartoma is tougher than in normal cerebral tissue, because they have a more gliosis as compared to the normal tissue, but they have the nervous tissue. So that's why the differentiation is very tough, and you should be good in the anatomy, and you should be used with the help of the, we can say, there is the image guided system which can not allow you to go beyond that, and you can notice it is slightly browner in color, but it's very tough to identify, and relatively avascular, and usually differentiated from the surrounding normal cerebral tissue. It's not easy, but definitely the experience will tell you more. As much as you are operate, as much as then definitely you are good in that. And the perforating arteries from the basilar apex and demarcate the posterior limit of the dissection. And for some large, we can say the hypothalamic hamartoma, the optic chiasma is helpful to choosing the ideal trajectory and identify or defining the margins for the resection. And closure is done in a standard fashion. Definitely bleeding, try to avoid as much as possible, and it is definitely not difficult to control the bleeding unless until you are hitting some major or minor artery here. And you no need to hit any major or minor artery. If you can just make a little damage over that, even though it is caused the disconnection, and you can get your goal. Closure is done in a standard fashion and with the watertight closure of the dura, and followed by the replacement of the bone flap, and the scalp is closed in a layered fashion. And then skin is, we can see, and we can say the reapproximated appropriately up to your choice, if you want to use the staples or we can say the proline. It's up to you. And the patient head should be taken out of the Mayfield holder, and sterile dressing should be applied, and patient kept in the ICU for 28 to 48 hours. So I try to explain you in detail. I hope you will like it. If you like it, and subscribe and share and support us. I know you are worried about the longevity of the lecture, but these are not the entertaining lecture. But these are the educational lectures, and those people definitely are listening, that definitely they have to bring the time for them and they understand. Thank you. See you with the new lecture.